This is Dr. James Marion broadcasting live via Zoom yet again as we reach the tail end of what I hope will be, or the true tail end of the COVID era, here at the Feinstein IBD Center with a very special guest, a colleague of mine who I thoroughly enjoy working with and who is a real national and international leader in her field. This is Dr. Aimee Lucas. Dr. Lucas is an associate professor of medicine here at the gastroenterology division at the Icahn School of Medicine. Dr. Lucas's clinical practice covers everything. However, she's her research and her work and her writing and her expertise is a particular interest in hereditary cancer syndromes and how to define what those real risks are, and including all gastrointestinal cancers, not just colon cancer, but pancreatic cancers as well. Aimee, it is such a pleasure to finally have you on this broadcast. Welcome.
Thank you so much, Dr. Marion. I'm so happy to be here.
Well, Aimee, you can call me Jim, please, because otherwise I feel really old.
All right, Jim.
So listen, Aimee, I want to start very basically, because really the title of this is, what hereditary cancer should IBD patients be aware of or concerned about? I don't want to use the word worried, right? Because, there's a lot of dread that comes up about this. Oh, I got a blood test that told me I've got a 15% chance of getting something, right? That's hard to live with for the rest of your life. Let's start basic. What is hereditary cancer?
So hereditary cancers, and particularly here, we'll talk about all the gastrointestinal cancers, which range from stomach cancer, small intestine cancer, colon cancer, pancreatic cancer, and a few others, are cancers that seem to cluster or run more in certain families than others. And so one of the hallmarks of hereditary cancer syndromes is a young onset of a particular cancer, like a colon cancer, and we're hearing a lot more about those these days, or families where we might see more than the number of cancers that we would otherwise expect to see in a family. And it might not just be intestinal cancers, it might be some other cancers, and there are other cancer syndromes, not to get too much into the weeds. But when we're starting to see more cancers than we would usually expect to see in a family, that's when we start to think about hereditary cancer syndromes.
So our IBD patients, Aimee, most of our IBD patients, I should say, already carry the burden of an increased risk of colon cancer and maybe prostate cancer we're discovering for some of our Crohn's patients, although that data is somewhat new and I think undeveloped. But let's focus on colon cancer for a minute. What hereditary versions of colon cancer, in addition to this sort of different baseline risk that these patients have, should they be particularly aware of? Focusing on colon cancer just for a minute.
So that's a great question. And, what I actually tell a lot of my patients who are worried about a family history of colon cancer, when they already have an inflammatory bowel disease, particularly a colitis, is the good news is your colon has already been examined many times by already an expert gastroenterologist in the field. And so they're not just evaluating your colitis at that time, but they're doing the same things that we would do, looking for polyps and other types of precancers so that those can be removed at the same time. So in many ways, it's actually very encouraging when I have a patient with inflammatory bowel disease, because I know that they've already had many times an expert looking at their colon already. But patients with inflammatory bowel disease are also at the same risk of having a hereditary cancer syndrome as anybody else in the general population. So there are a few things to look out for, one of which is a family history of colon cancer. And typically we look for colon cancers that happen usually in first degree relatives, so a mother, father, sister, brother, or child, And one of the sort of red flags there is if it happens under the age of, let's say, 60 or so, and particularly if it happens under the age of 50. And then there are a few other cancer syndromes, the most common of which is called Lynch syndrome. And Lynch syndrome actually affects just over, we think, around 1 in 300 individuals. And that's a hereditary cancer syndrome. So it can be passed from generation to generation. That does predispose to not just colon cancer, but other, cancers within the GI tract and outside of the GI tract, where we can implement certain screening and surveillance protocols to really reduce one's incidence of cancer if we're able to identify the hereditary cause. So those are some of the common things that we think about when we think about hereditary GI cancer syndromes.
So this is something, and again, I think what Dr. Lucas just mentioned, I want to emphasize to our viewers, this is to all of you who were sort of postponing things because of COVID in terms of having your screening colonoscopy, that whether I do it or Dr. Lucas does it for either hereditary cancer or the colitis driven cancer risk, you need to have your colonoscopies done regularly. So this is just a friendly reminder to get that box checked and taken care of. So Aimee, the idea of knowing one's family history, and again, these are things that have to be brought up, discussed at the dinner table. Ask those questions about your Uncle Max. Everybody's going to do that now, I hope, based on that recommendation. But there's been this explosion in these genetic tests and blood tests, and I even now see tissue testing done on our specimens for the last few years when I'll get, a dysplasia in the setting of colitis from the Mount Sinai lab. What role do all of these play in this? What tests should our patients consider once they've walked through the family history with their families?
Sure. So you're right. There are a lot of tests out there, and some of those tests, at least here in the United States, are marketed, directly to the patients. And so it's a lot to take in and it's a lot to understand. There are commercial products out there marketed directly to patients. I won't mention any specific names, but they go straight to the patients and they can tell you about your hereditary risk of breast cancer or your hereditary risk of colon cancer. Those are tricky because we don't know. They're really interesting, but we don't know if they give us the full sort of genetic history that we would get from a blood test or even a saliva test that we do in a medical practice to assess cancer risk. So they're a little bit different. Sometimes those commercial tests can tell us about the exact same genes that we're worried about when we hear about a strong family history of colon or other cancers. But some of those tests might miss some of the genetic causes of hereditary cancer syndromes. And so they might give somebody a false reassurance that their genetics are okay. And just because XYZ family members have had cancer, I'm okay. And so I don't have to do anything extra about it. So those are some of the blood tests that are kind of out there in the public that you can access and, pay out of pocket to get. We do similar blood tests on sort of the medical side, looking for cancer susceptibility genes. And some of the tests and the mechanisms are very similar, but some things that we look for are a little bit subtly different. And so if there is real concern for a hereditary syndrome, I think it's worthwhile to consult with me or with somebody else who does similar sorts of things to be able to understand what the tests are that we're doing. So those are blood tests or saliva tests that tell us about every cell in our body and what DNA changes we can pass on to our children, or we might change with our siblings or our parents with whom we share a reasonable amount of DNA. The other tests that you're discussing are tests that we can do on tissue. And here we can do certain tests on tumor tissue if there is a cancer, or we can do it on what we call dysplasia, which is kind of along the lines moving onto cancer. So for colon cancer in particular, Everybody who has a colon cancer that's diagnosed or the pathology specimen is sent to the Mount Sinai Hospital gets special tests called immunohistochemistry tests that actually look specifically for microsatellite instability, which is a fancy term that's associated with the tumor that's associated with Lynch syndrome, or looking for specific loss of certain staining patterns. It's a little bit complex, but basically we're trying to pick out who of the colon cancer patients actually has this hereditary type of hereditary cancer syndrome, so that perhaps we can give them targeted therapies that work really well and differently from other therapies, and so that those people can better understand what caused their cancer so that they can share that information with their family members, so that the family members can actually undertake testing themselves, and then also be very proactive about their own health to be able to reduce their cancer risk in the future. Yeah. Another type of test that we see done on tissue is looking for different changes in the tissue DNA. That's a bit more complex, that I think if it came time for that, it's worth a conversation with your treating provider.
So buyer beware before you shell out for one of these tests, and most importantly, ask an expert like Dr. Lucas, I think, or I'm happy to answer.
Jim, I would really say buyer beware, because one of the things that some people might not appreciate is that having one of these genetic abnormalities might actually impact your ability to get important things in life, like life insurance. Yep. And so it's important to think about ahead of time. We do have certain protections in place here in the United States. There's a law called GINA, the Genetic Information Non-Discrimination Act, which was signed, I believe, in 2008, that protects people who have these hereditary cancer syndromes. But if we find one of these syndromes, some people might not qualify for life insurance, or it might be very expensive. And so if you're 25 and thinking about getting one of these commercial tests, that's something to consider ahead of time, because at least not all of my 25-year-old patients are thinking about life insurance and things all the way down the road. So it's an important conversation to have before you embark on one of these tests. Something to think about.
And I'm resisting, even though I'm not 25 anymore, because I'm afraid it's going to say that I'm part Beagle or something. So I'm going to step back from that one.
My mom jokes that she's part Neanderthal.
I know it's in there. So listen, Aimee, we're talking about colon cancer, but any other particular cancers that you think about? I know a lot of your work has been on pancreatic cancer. I always worry that we're generating a lot of dread in our patients by saying, this test showed this, and this is what your risk is, and the like. But any other closing thoughts on, any other cancers that you think we can more reliably predict or help prevent by using these tests?
Sure. So you mentioned I do a lot of work in pancreatic cancer, and I know we've had a lot of discussions around this in the past. And that's a whole topic for another conversation. You and I can debate some other time. Yeah. But, I think for pancreatic cancer in particular, our assumption over time has been that this is something that happens to people who are at an older age, perhaps drank too much or smoked too much or just had really bad luck. And it turns out that pancreatic cancer, like colon cancer, like breast cancer, can actually run in families. Mm-hmm. It does not mean that every pancreatic cancer has a hereditary cause, but certain individuals, typically who have multiple family members who have been diagnosed with pancreatic cancer, do seem to be at higher risk. And so we share a few patients. And so we do talk about risk-based screening for people who do have increased risk, but this is something that really should be done typically under research settings and with somebody who specializes in something like that.
Well, Aimee, I am so glad you came on, and I actually do look forward to continuing our debate and our discussion and our collaboration and our caring for our patients. So thank you for joining me, and we're going to have you back again, I know, because you're making all of these wonderful discoveries in the field. And So thank you.
Thank you so much for having me.
So listen, this is Dr. James Marion, wrapping up a third Thursday live on-tape Zoom broadcast from the Susan and Leonard Feinstein Inflammatory Bowel Disease Center at Mount Sinai Medical Center here in New York City with Dr. Aimee Lucas, discussing hereditary cancers that IBD patients should know about and be concerned about. Thank you for joining us, and I look forward to seeing you again next month.